Welcome to the Funnel Effect.
Glad to be here.
Today, we are diving into a 2026 expert review from Eurointervention titled Non-Invasive and Invasive Diagnostic Modalities for the Assessment of Coronary Vasomotor Dysfunction in ANOCA patients. This comprehensive research is brought to us by authors Isa Bilo, Janneke Woodstra, Elif Arribas, Suzette E. Elias Smale, Caitlin Vink, Jan J. Peek, Dirk J. Dunker, Janine E. Reuters van Lennep, Miriam Kavusi, and Jolande Appelman from the Amsterdam UMC and Erasmus MC in the Netherlands.
That is quite the roster of experts. I mean, combining Amsterdam UMC and Erasmus MC brings a lot of clinical weight to this.
It really does. Okay, let's unpack this, because our mission today is to explore a genuine medical mystery that has frustrated the cardiology community for decades.
Right.
We are looking at ANOCA angina with non-obstructive coronary artery disease and tracing the medical community's intense ongoing quest to diagnose hidden invisible heart pain without having to resort to invasive surgical procedures.
Imagine having severe chest pain, like severe crushing chest pain. You go to the emergency room, you are rushed into the cath lab for a diagnostic coronary angiogram, and the interventional cardiologist comes back to tell you that your arteries are completely clear.
Which sounds like good news at first, right?
It does, but there is no obstructive CAD. By all traditional visual metrics, the large vessels supplying your heart look perfectly fine, but it still hurts.
Yeah.
And you know something is wrong. That is the terrifying reality for a massive segment of the population. In this deep dive, we are going to equip you with a cutting-edge understanding of how the heart's microscopic plumbing actually works, why it sometimes fails invisibly, and how doctors are battling to find those failures without physically threading wires into your chest.
That scenario, that is what really hooked me when reading this paper. We know our audience follows cardiology and understands the basics of CAD, but the sheer scale of the anotia problem is staggering. The research states that 2/3 of females and 1/3 of males who undergo a diagnostic coronary angiogram for suspected CAD actually do not have obstructive disease.
2/3.
Let that sink in. 2/3 of women are going into a cath lab with classic ischemic symptoms, and the traditional angiogram is basically shrugging its shoulders.
Yeah.
That is a massive demographic of patients actively suffering while looking, perfectly healthy on a standard macro-level scan.
The human impact here is profound. I mean, we are dealing with a population that suffers from a severely impaired quality of life. They live with a high, relentless burden of angina, and crucially, the clinical data proves they have a higher incidence of adverse cardiac events later on.
So it's not just in their heads.
Exactly. But for decades, before the mechanisms of ANOCA were better understood, a lot of these patients, and predominantly women, were unfortunately dismissed.
Right.
They were told it might be musculoskeletal or gastrointestinal or even psychological, simply because the traditional imaging tools weren't sophisticated enough to spot the biological failure. But their pain is real, the ischemia is real, and the long-term danger is very real.
Right, and the text gives us a clear framework for what is actually going wrong. Between 60 to 90% of these ANOCA patients have what is broadly termed coronary dysfunction.
Yeah.
So it's not a macroscopic structural blockage like a calcified plaque. It's a functional or microscopic problem. To visualize this, we have to contrast the macrocirculation with the microcirculation.
Exactly. You can picture the heart's blood supply as a city's transportation grid. On the surface of the heart muscle, you have the macrocirculation. Those are the large epicardial coronary arteries.
The multi-lane highways.
Yes, the multi-lane highways. This is what a traditional angiogram sees. When the doctor says your arteries are clear, they mean those major highways have no traffic jams.
No pileups.
Right. But branching off from those highways, diving deep into the actual myocardium, the heart muscle tissue, is the microcirculation. These are tiny, hair-like vessels, some of them smaller in diameter than a human hair. Think of these as the intricate network of small, winding neighborhood states.
Okay, I see.
In ANOCA patients, the highways are wide open, but the neighborhood streets are failing, effectively starving the heart muscle of oxygen.
And the paper enthusiastically categorizes exactly how those neighborhood streets fail. It breaks this dysfunction down into 3 main endotypes.
Right.
Number 1 is coronary vasospasm, number 2 is coronary endothelial dysfunction, and number 3 is coronary microvascular dysfunction, or CMD.
What's fascinating here is that these aren't just subtle variations of the same disease, they are completely distinct biological and mechanical failures. Well, a vasospasm is a violent, hyperreactive clamping down of the vessel muscle. Endothelial dysfunction is a chemical communication failure within the inner lining of the blood vessel. And CMD involves broader issues with flow capacity and structural resistance deep in the capillary beds.
So they require totally different approaches.
Absolutely. Identifying the specific endotype a patient has is the whole ballgame. If you just throw generic nitrates or calcium channel blockers at an ANOCA patient without knowing your endotype, you might not do anything to improve their quality of life.
Because you're treating the wrong mechanical issue.
Exactly. Tailoring the medical therapy requires knowing exactly which microscopic mechanism is breaking down.
Which sets up the core conflict of our deep dive. How do you figure out which of those microscopic failures is happening when you can't see them on a normal scan?
That is the million-dollar question.
The current benchmark, the absolute gold standard recommended by European, Japanese, and American guidelines, is invasive coronary function testing, or ICFT. But this is not a casual checkup.
Not at all. ICFT is an intense, highly specialized procedure. To get these answers, an interventional cardiologist must physically thread ultra-thin, sensor-tipped wires directly into the epicardial arteries.
Like while the heart is beating.
While the heart is actively beating, yes. The paper specifically mentions advanced tools like the combo wire XT or the pressure wire X. These are microscopic marvels of engineering.
Yeah, the specs on those are insane.
Right. While sitting inside the beating heart, these wires continuously measure intraluminal pressure, the physical temperature of the blood, and the exact flow velocity. Specifically, the average peak velocity, or APV. They are gathering real-time, high-fidelity data from the inside out.
But they don't just put the wire in and watch. They have to actively provoke the heart to see how it reacts under stress.
Right. That is the crucial part.
They use a specific set of chemical stressors to force the vessels to reveal their hidden flaws.
Exactly. They use acetylcholine, or Aishi, to test for 2 different endotypes depending on the dose.
Okay, break that down for me.
At high doses, around 100 to 200 micrograms, they inject AST directly into the artery to intentionally provoke a vasospasm.
Wow.
Yeah. And at lower doses, just 2 to 20 micrograms, they use it to test for endothelial dysfunction.
Okay, and then there's a third drug.
Yes. For the third endotype, they use adenosine. Adenosine is a non-endothelium-dependent vasodilator. It forces the microcirculation to open up completely independently of the vessel lining, which allows the doctors to measure the absolute flow reserve and resistance deep in the tissue.
I really want you to consider the reality of this test from the patient's perspective. You are awake on the table, you have a wire physically sitting inside your coronary artery, and the medical team is deliberately injecting chemicals to trigger the exact agonizing chest pain you came to the hospital to cure.
It's daunting.
Very. The text outlines the severe disadvantages of this. It is inherently invasive. There are procedural risks, including the potential for vascular damage from the wire itself, or triggering dangerous, unstable arrhythmias.
Plus the logistical barriers.
Right. It requires a highly specialized cath lab setup, which means high costs and limited availability.
Yeah.
And, of course, the significant patient discomfort. This is why the medical community is on this massive quest. Can we get these same vital answers without physically entering the heart?
It's the holy grail of modern diagnostic cardiology, replacing the wire with a scan. But to understand why that is so incredibly difficult and why the paper ultimately reaches such a sobering conclusion, we have to look at each of these 3 endotypes one by one, starting with coronary vasospasm.
Let's do it. What actually is a vasospasm on a biological level? If there's no physical plaque blocking the artery, what is suddenly stopping the blood flow?
It comes down to the smooth muscle cells that wrap around your blood vessels.
Okay.
These cells are supposed to smoothly regulate the vessel's diameter to control blood pressure and flow. But in a vasospasm, these smooth muscle cells are hyperreactive.
Like a cramp.
A very severe cramp, yes. Normally, when a chemical like acetylcholine interacts with a healthy vessel lining, the endothelium, it triggers the release of nitric oxide. Nitric oxide is a powerful vasodilator. It tells the smooth muscle to relax, widening the vessel.
But I'm guessing that doesn't happen here.
Right. In a patient with this endotype, the smooth muscle ignores the normal signals and violently contracts. So when triggered by that high-dose acetylcholine during the ICFT, instead of relaxing, the vessel severely constricts, effectively strangling the heart muscle and causing acute ischemia.
And the researchers rely on standardized criteria from the Covatus group to categorize these spasms. The criteria are very specific.
Very strict guidelines, yes.
For an epicardial vasospasm, meaning the spasm is happening in those large surface highways, they look for a narrowing of the artery by more than 90%, accompanied by patient angina and clear ischemic changes on an ECG.
That's the macro level.
But for a microvascular vasospasm, the large epicardial arteries narrow by less than 90%, yet the patient still experiences the exact same severe angina and ischemic ECG changes. This proves the spasm is happening deep down in those invisible, microscopic neighborhood streets.
Exactly. The challenge for non-invasive diagnostics is figuring out how to trigger and observe that violent clamping down without a wire inside to monitor the physical diameter of the vessel. The primary non-invasive attempt the text discusses is something called a hyperventilation and cold pressor test, or CPT.
I have to say, reading the methodology for this test felt like reading about a medieval endurance trial.
It really does.
The patient is hooked up to a continuous 12-lead ECG. Then, they're instructed to forcefully hyperventilate for 6 straight minutes.
Which is exhausting on its own.
And if that wasn't enough to make you dizzy and distressed, immediately after those 6 minutes, they have to plunge their right hand into a bucket of iced water and hold it there for 2 minutes. 6 minutes of hyperventilation followed by an ice bucket. It sounds more like an extreme reality TV stunt than a modern diagnostic procedure.
It is incredibly grueling for the patient, but the biological mechanism behind it is entirely sound.
How does that work?
It's all about weaponizing the sympathetic nervous system. When you forcefully hyperventilate, you trigger a fight-or-flight response, causing a massive systemic release of catecholamines, like adrenaline.
Okay, the body goes into panic mode.
Right. These hormones naturally provoke vasoconstriction. They tell your blood vessels to tighten up in preparation for a threat. Then, the immense physical shock of the ice water further amplifies that sympathetic stress response.
It just stacks the stress.
Exactly. In a healthy person, the endothelium releases enough nitric oxide to counterbalance this stress and keep the coronary arteries open. But in a patient with hyperreactive smooth muscle, this massive 1-2 punch of hyperventilation and extreme cold overwhelms the system, provoking a full-blown coronary vasospasm that can hopefully be detected on the ECG.
And historically, the data suggested this might actually work. The text brings up a 2001 study by Hirano and colleagues. They ran this hyperventilation and cold pressor method on 43 patients suspected of having vasospastic angina.
And the numbers were impressive.
The numbers looked phenomenal on paper. Compared to the invasive wire angiography, this non-invasive test had a 91% diagnostic accuracy, 90% sensitivity, and 91% specificity. So what does this all mean? If it's over 90% accurate, why isn't this the standard of care?
Because accuracy is only one part of the clinical equation. First, as we just discussed, the patient experience is dreadful. Deliberately inducing acute chest pain while forcing a patient to hyperventilate and endure freezing temperatures is not something easily implemented in a busy outpatient clinic.
It's just too rough on them.
It is, but the fatal scientific flaw is that this test cannot differentiate between an epicardial vasospasm and a microvascular vasospasm.
I see.
The ECG just tells you that ischemia is happening somewhere. As we established, making the distinction between the macro and micro levels is absolutely crucial for targeted therapy. The external test lacks the spatial resolution to see exactly which neighborhood street is clamping down.
Which naturally led researchers to try using advanced imaging to get that spatial resolution. The text details a study by Pirzolo using stress cardiac magnetic resonance imaging, or CMR, on 129 patients.
The MRI approach.
Right. They wanted to see if they could use an MRI to spot the spasms. They tracked a metric called the Myocardial Perfusion Reserve Index, or MPRI, which compares blood flow during stress to blood flow at rest. Pirzolo looked at 129 patients, and honestly, on first read, I thought using a high-tech MRI was going to be the silver bullet. But why didn't it work for the microvessels?
It's a brilliant question, and the answer perfectly illustrates why replacing invasive tests is so scientifically complex. The MRI did spot the epicardial spasms. Patients with those major vessel spasms showed a significantly lower MPRI. But for microvascular spasms, the MRI failed completely.
It just missed them.
It couldn't detect a statistical difference. Why? It all comes down to the stressor. Stress CMR uses an intravenous infusion of adenosine to stress the heart.
Okay.
But adenosine is an endothelium-independent stressor. It operates on a completely different physiological pathway than acetylcholine, which is an endothelium-dependent stressor.
I think I'm following.
Vasospasms are fundamentally an issue with the endothelium and the smooth muscle. Trying to detect a vasospasm using adenosine is conceptually flawed. It's like trying to test the wiring of a house's heating system by turning the plumbing on and off. You are probing the wrong biological pathway.
So, synthesizing the data from the paper, the conclusion for this first endotype is incredibly sobering. Despite the hyperventilation, the ice water, and the advanced MRI scanners, there is currently no reliable non-invasive test for coronary vasospasm.
Them that all.
If you need to know if your heart's arteries are violently clamping down, and specifically where they are doing it, you absolutely have to use the invasive wire and the acetylcholine injection.
It is a harsh reality, and that complexity only deepens as we move to the second endotype, coronary endothelial dysfunction.
Let's transition right into that. We touched on the endothelium just a moment ago with the nitric oxide pathway, but let's really explore what happens when this inner lining gets sick. It's not a sudden mechanical spasm, it's a failure of cellular communication.
Precisely. The endothelium is not just an inert tube that blood flows through, it is a highly dynamic, metabolically active organ. When it is healthy, it constantly senses the physical shear stress of the blood flow and releases chemicals to manage the vessel's tone.
So it's actively regulating all the time.
Yes. The key diagnostic tool here is the low-dose acetylcholine test during the ICFT, just 2 to 20 micrograms. In a normal vessel, that tiny dose stimulates the endothelium to produce nitric oxide, causing a gentle, healthy vasodilation.
It opens up.
Right. But in endothelial dysfunction, the lining is damaged or exhausted. It fails to produce nitric oxide. So the acetylcholine bypasses the lining, hits the smooth muscle directly, and causes impaired vasodilation or even active constriction.
And the researchers have strict, highly specific metrics to define this failure invasively. For epicardial endothelial dysfunction in the large vessels, they look for constriction of more than 0% or more than 20% of the minimal lumen diameter compared to baseline.
Right. Any shrinkage is a red flag.
Basically, if it shrinks at all when it should be expanding, that's dysfunction. For the microvascular level, they measure the volumetric coronary blood flow. If the absolute flow increases by less than 50% in response to the acetylcholine, that confirms microvascular endothelial dysfunction.
So, knowing exactly how to measure this dysfunction from the inside, the researchers again tried to figure out how to see it from the outside. And once again, they turned to the cold pressor test.
The ice bucket returns.
The ice bucket is back. But this time, instead of pairing the ice water with an ECG and hyperventilation, they paired it with advanced imaging, specifically MRI or positron emission tomography, PET scans.
The theoretical biology behind pairing the CPT with an MRI is actually really elegant. The idea is that the sudden cold stimulus on your hand increases your sympathetic nervous system activity, which drives up your heart rate and blood pressure.
Exactly, getting the system pumping.
This surge pushes a higher volume of blood through your coronary arteries, which increases the physical shear stress, the actual friction of the blood cells against the vessel walls. In a healthy endothelium, that physical friction should cause flow-mediated vasodilation. The endothelium should feel the rush of blood, release nitric oxide, and open the vessel wider.
It is a beautifully logical theory. Use the body's own physical hemodynamic reactions to test the chemical lining of the heart. But when they put it to the test in large-scale clinical trials, the theory fell apart in practice.
The paper details 2 major studies that tried to prove this worked. The first is the Landis study, which focused on a fantastic cohort of 189 female patients suffering from ANOCA. They compared the invasive acetylcholine test directly with the non-invasive CPT combined with MRI.
A great direct comparison.
And the result? They found absolutely zero correlation. None. The external test was completely unable to predict what the internal wire was seeing.
It's disappointing.
Then there's the Thompson study, looking at 118 females. They used an adenosine-induced MRI to try and spot the dysfunction. They found a correlation, but it was incredibly weak. Why did this elegant theory fail so spectacularly in the scanner?
If we connect this to the bigger picture, the failure comes down to the fundamental limitations of non-invasive imaging modalities. The external scanners, whether MRI or PET, are essentially measuring a semi-quantitative ratio of stress-to-rest perfusion upslopes.
Meaning they just see the general flow of blood.
Exactly. They are looking at the overall cloud of blood flow moving through the myocardial tissue. But the invasive ICFT is measuring exact microscopic physical changes in the diameter of a specific epicardial artery, combined with precise volumetric blood flow velocity.
The scanners just aren't sharp enough.
Furthermore, just like with the vasospasm tests, the CPT, combined with imaging, completely fails to distinguish between microvascular and epicardial endothelial dysfunction. And let's not forget the practical reality here.
The patient experience again.
Yes. Keeping a patient perfectly breath hold still inside a claustrophobic MRI tube while their hand is submerged in freezing water for 2 minutes is an absolute nightmare for both the imaging technicians and the patient. Any movement ruins the scan.
The text does briefly mention some emerging technologies that are taking a totally different approach. Instead of trying to look directly at the heart while the patient is in an ice bath, they look at the peripheral blood vessels in the arms or legs.
Right, moving away from the chest.
Operating on the theory that if the endothelium is sick in your forearm, it's probably sick in your heart, too. They mention flow-mediated dilation and something called ALASCA, which stands for laser speckle contrast analysis, to look at peripheral vascular smooth muscle cells.
Those are genuinely fascinating technologies. They are entirely non-invasive and show real promise for evaluating general systemic vascular health. But the paper makes it explicitly clear that right now they require significant further research to prove clinical utility for ANOCA.
They aren't ready for prime time.
No. The heart's microcirculation is uniquely complex and operates under different hemodynamic pressures than your arm. You cannot definitively diagnose coronary endothelial dysfunction based purely on a peripheral scan. So, once again, the conclusion for this second endotype is a locked door. There is still no reliable non-invasive substitute. The invasive wire remains supreme.
That brings us to the final piece of the ANOCA puzzle, and honestly the most intricate one. Coronary microvascular dysfunction, or CMD.
This is the big one.
This is where we are dealing strictly with those microscopic neighborhood streets deep in the myocardium. To even begin to understand CMD, we had to split it into two distinct physical metrics. The first metric is coronary flow reserve, or CFR.
CFR is a measure of the microvascular network's total capacity to dilate and increase blood flow when the heart is under maximum metabolic stress.
Like when you're exercising.
Right. Think of it as measuring the absolute maximum volume of traffic those neighborhood streets can handle during rush hour. Invasively, they measure this using that Doppler wire to calculate the ratio of hyperemic blood flow velocity, meaning the flow when the heart is chemically stressed with adenosine compared to the resting flow velocity.
And what are the normal ranges for that?
A normal, healthy CFR is greater than 2.5. That means your heart can increase its blood flow by more than 2.5 times its resting rate when it demands it. If your CFR is less than 2.0, that is definitively abnormal and diagnoses you with CMD. Anything between 2.0 and 2.5 is considered a borderline gray zone.
Here's where it gets really interesting, because after all the crushing failures with vasospasms and endothelial dysfunction, we finally have some legitimately good news for non-invasive testing.
Finally.
When it comes to purely measuring coronary flow reserve, doctors can actually get highly reliable results from the outside.
Yes. This is the one major victory for non-invasive diagnostics in this entire expert review. The absolute gold standard for measuring CFR non-invasively is a PET scan. But not just a standard PET scan specifically, one using oxygen-15 labeled water as a radioactive tracer.
That sounds incredibly specialized.
It is. When they administer adenosine to stress the heart, this specific type of PE scan can quantify the absolute myocardial blood flow in milliliters per minute per gram of tissue. It correlates excellently with the data you get from an invasive Doppler wire.
But there's a massive logistical catch here. Oxygen-15 PP scans are incredibly expensive. They expose the patient to ionizing radiation, and because oxygen-15 has a radioactive half-life of only about 2 minutes, you essentially need a multi-million-dollar particle accelerator, a cyclotron, sitting in the basement of the hospital to produce the isotope on demand.
Yeah, you can't just order that in a rural clinic.
Yeah, exactly.
Yeah.
It has extremely limited availability globally. So the researchers looked for a cheaper, wider-reaching hero, and they found it in something called TTDE, transthoracic Doppler echocardiography.
TTDE is remarkable because it leverages standard ultrasound technology, which is widely available, relatively inexpensive, and involves zero radiation.
Just a normal ultrasound wand.
Basically. The technician places a high-frequency ultrasound probe on the patient's chest, specifically hunting for the left anterior descending artery, the LAD, using a modified 2- or 4-chamber view with color Doppler flow mapping. Once they manage to lock onto that specific artery, they measure the flow velocity at rest, infuse adenosine to induce hyperemia, and measure the flow velocity again.
And the evidence supporting this is incredibly strong. The text cites 3 different prospective studies: the Bartel study with 51 patients, the Kim study with 17 patients, and the Yang study with 37 patients. All of them showed an excellent correlation with the invasive Doppler wire.
The accuracy is undeniable.
The success rates for getting a readable assessment of the LAD artery were 98%, 81%, and 93% respectively. Why does this work so perfectly when everything else failed? Because for the first time, the non-invasive method and the invasive method are actually measuring the exact same physiological reaction.
Yes, the ratio between rest and hyperemic flow velocity provoked by the exact same drug, adenosine.
It makes perfect sense.
It is a true apples-to-apples comparison. But as with all things in clinical medicine, it is not a perfect silver bullet. TTDE has significant physical caveats. Think about what the sonographer is actually trying to do. They are trying to find and hold a clear acoustic image of an artery that is literally a few millimeters wide, beating furiously inside a moving heart while the patient is breathing heavily from the stress drug.
Sounds nearly impossible.
It requires immense, highly specialized operator training. It is an art form as much as a science. Furthermore, the fundamental physics of ultrasound dictate that sound waves struggle to penetrate thick adipose tissue or air. So it is physically challenging and sometimes impossible to get a usable image on patients who are obese.
Right.
Additionally, because the stressor drug adenosine often causes severe dyspnea or shortness of breath, patients with COPD frequently cannot tolerate the test.
And we should briefly mention the MRI again. We talked about CMR failing for vasospasms, but what about for flow reserve? The results in the text are highly conflicting.
Very mixed data.
The Thompson study found absolutely no correlation between the MRI's perfusion index and the invasive wire's flow reserve. But the Raman study found that if you set a very specific threshold, an NPR of 2.19, the MRI actually showed excellent specificity for detecting abnormal flow reserve. So MRI is a maybe, but TTDE and PT are the clear clinical frontrunners for non-invasively measuring flow.
But, and this is a monumental but that the paper heavily emphasizes, flow is only half the story of microvascular dysfunction. You have the flow reserve, CFR, but you also absolutely have to measure resistance, denoted as MOR.
Let's unpack that second half, resistance. Why does it matter if we know the flow is bad? Don't we just need to know if the flow is bad to diagnose the patient and move on to treatment?
Knowing the flow is reduced tells you that there is a problem, but it doesn't tell you the structural reality of the microcirculation. Invasively, doctors measure 2 metrics to understand resistance: HMR, which is hyperemic microvascular resistance, where an abnormal reading is greater than 2.5, and IMR, the index of microvascular resistance, where anything over 25 is abnormal.
And why do we need both flow and resistance?
By measuring both flow and resistance, doctors can subcategorize the dysfunction. If a patient has low flow A and D, high resistance, they have structural CMD. The actual architecture of the microvessels is physically damaged or remodeled. The pipes have thickened and stiffened.
Okay, structural.
But if a patient has low flow but normal resistance, they have functional CMD. The pipes are structurally fine, but the biological signals controlling their dilation are failing. The clinical pathways for treating structural versus functional CMD can be entirely different.
Okay, let's use a physics analogy here to really nail this down. If CFR, the flow, is just how fast the water is moving out of the garden hose, then MR, the resistance, is whether the hose is physically kinked or if the faucet is just turned down.
That's a great way to picture it.
So if we can measure the flow of the water non-invasively with an ultrasound or a PT scan, how do we measure the resistance from the outside?
We drop the bad news. We can't. It is fundamentally mathematically impossible with current non-invasive technology.
It's just like nothing.
Nothing. To calculate microvascular resistance, you absolutely must measure the physical pressure inside the vessel simultaneously with the flow. Going back to your hose analogy, you cannot calculate the internal resistance of the pipe just by looking at how fast the water is exiting the nozzle. You have to know how hard the water is pushing against the internal walls.
And scans can't feel pressure.
Exactly. Non-invasive tools, whether it's an MRI, a PET scan, or an ultrasound, can only visualize the velocity or the perfusion of the tissue. They are completely, totally blind to physical intraluminal pressure.
The text details studies by Kotecha in 2019 and Pargankar in 2019 that desperately tried to find a workaround for this physics problem. They tried to mathematically link the invasive IMR metric with CMR imaging and stress echocardiography, hoping they could find a visual surrogate for pressure.
They tried really hard.
But they couldn't. The data clearly shows that external imaging cannot replace the need for hard physical pressure data. If you need to know the resistance, you need a wire.
However, the paper does highlight a fascinating intermediate compromise that is emerging in the field: angio-IMR. It's not totally non-invasive, but it represents a massive leap forward in procedural safety.
Yeah, this angio-IMR is incredibly cool. It's described as a wire-free, drug-free, invasive alternative. The patient still has to undergo a standard coronary angiography, so they still have a catheter injecting contrast dye to visualize the large arteries.
Right, so you're already in the cath lab.
But instead of threading that ultra-thin, expensive, risky pressure wire deep into the microvessels, and instead of injecting adenosine to chemically stress the heart, they use a computer. They take the standard 2D angiogram images and use advanced computational flow dynamics.
It's essentially reverse engineering the physics.
Exactly. The software literally analyzes the speed of the contrast dye moving through the vessels frame by frame, builds a 3D model, and retroactively calculates and estimates the distal pressure and flow.
It is a brilliant application of physics and advanced computing. It provides a fully invasive level metric, giving you that crucial IMR number without the added procedural risk, time, and discomfort of navigating the delicate pressure wire and inducing hyperemia.
It's a huge step.
It is officially classified as intermediately invasive, and the recent studies highlighted in the review strongly support its feasibility and accuracy in patients suspected of having ANOCA. It is highly promising for the near future of cath labs.
So let's step back and synthesize everything we have covered on this journey through the heart's hidden plumbing. We started with millions of patients, largely women, suffering from agonizing, life-altering chest pain, but showing perfectly clear arteries on standard scans.
The invisible disease.
We learned that their pain is caused by microscopic failures, vasospasms, endothelial dysfunction, or microvascular dysfunction. We looked at the immense physical and financial toll of the invasive ICFT wire testing required to diagnose them. And we scoured the latest medical research to see if external scans could save them from the wire.
And the clinical scorecard is undeniably heavily weighted in one direction. We can reliably measure exactly one metric from the outside, coronary flow reserve, using a PET scan or a TTDE ultrasound, but we cannot non-invasively measure microvascular resistance. We cannot non-invasively evaluate endothelial dysfunction, and we cannot non-invasively detect or locate coronary vasospasms.
Which brings us to the ultimate, sobering reality of this expert review. It's not just that non-invasive tests miss 3 out of the 4 major metrics. It's how these diseases actually present in real human beings.
This raises an important question. If most ANOCA patients do not just have one isolated problem, but rather suffer from a complex combination of these overlapping endotypes, for instance, a patient might have microvascular spasms and structural CMD simultaneously, what good is a non-invasive test that can only see one isolated piece of the puzzle?
You're flying blind.
Exactly. If a cardiologist only uses an ultrasound to check their flow reserve, they might look at a normal CFR reading and tell the patient they are fine, completely missing the fact that their endothelium is exhausted and their arteries are violently spasming under stress.
You would be putting them right back in the exact same frustrating, terrifying position they started in years ago, in pain but told they are medically clear.
Precisely. And that clinical danger dictates the paper's final definitive verdict. Because a comprehensive understanding of all these overlapping endotypes is absolutely required to prescribe the correct, tailored medication to treat ANOCA properly, and because non-invasive methods simply cannot capture all of these endotypes, invasive coronary function testing, the ICFT with the wires and the chemical stressors, remains the absolute indispensable gold standard.
It's unavoidable.
The authors conclude that until revolutionary new external technologies are invented, comprehensive invasive testing must be in the armamentarium of every single interventional cardiologist treating these patients.
It is a profound conclusion that validates the suffering of so many patients while charting a clear, albeit highly technical and challenging, path forward for their treatment. It is a stark reminder of how incredibly complex the human heart truly is, and how hard we have to work to uncover its microscopic secrets.
It really is. And looking forward, reading about that angio-IMR technology leaves you with a truly provocative thought to mull over. They are already using computational flow dynamics to retroactively calculate hidden physical pressure from a standard 2D X-ray video of dye moving through the heart.
Right.
As artificial intelligence, machine learning, and spatial computing advance exponentially over the next decade, could we eventually reach a point where we take a simple, entirely non-invasive, ultra-high-resolution 3D scan of a patient's chest, feed that structural data into a massive AI physics engine, and perfectly, instantly simulate the exact physical pressure, the complex fluid dynamics, and the chemical reactions of every single microscopic vessel in their heart? Could silicon and code eventually make the physical wires entirely obsolete?
Thank you for watching The Funnel Effect.